I'm going to use some of the slides from yesterday in order to try to teach a slightly separate concept today, which is how you can go work with people in low and middle income countries and develop policies and understandings that can make a remarkable improvement in their reality, and how they can do it themselves with actually not much help, with the other lesson that you need to let them derive the questions and the answers, because it's easy, as we just heard, to fall into the trap of exporting your own ideas to their reality, and they don't necessarily fit. So I'm going to talk about a treatment algorithm for management without ICP monitoring, improving outcome efficiency. I'm going to focus mostly on how we get there, because I think it's a good model in terms of how everybody can get there. Okay, so this group of practitioners, of which I am a prime example, practices in the IV tower. We have minimal and no resource restrictions. We adopt new technology early. We have access to monitors and treatments not generally widely available. And of course, those are the ones who publish. So when you go to the literature, you see our stuff from this particularly small group of the world. What proportion of the global traumatic brain injury population will be managed by academics? I can't get enough zeros in there, really. It's just not even an important number. So even in high-income countries, the majority of brain injury patients are managed without ICP monitoring. To be honest, from the National Trauma Database, not the advocates, but just the realists, it's really quite low. It's probably 18% of people who are candidates for ICP monitoring in the US actually get monitored. So it isn't just LMICs that don't monitor. 90% of TBI is treated without ICP monitoring in the year 2019. So that we have to address that population. We can't ignore it. Now, this was the trial that we did in Latin America, and I can say that the authorship was 80% low and middle income people, and that it's probably a pretty good mark on your CV when your only publication's a New England Journal publication. And we have an awful lot of people in Bolivia and Ecuador who can claim that. But what we used in the non-treatment protocol, in the non-ICP protocol, was the ICE protocol, imaging clinical examination. As I said yesterday, it was quite effective, actually. The question is, though, is it effective and is it optimized? We made it up for that study, and it did pretty well. But in the reality of the middle-income countries in South America, what did it actually mean? So we actually got funded to study that in a prospective fashion, funded by the NIH. And so we set up this study. It was 2 phases. Outcome measures were 6-month composite and Glasgow outcome score. And we measured a bunch of process variables, length of stay in ICU, ventilator use, et cetera. And this is the centers in which we did it. A number of these centers were centers from the BEST TRIP trial. So they were already experienced in the protocol. So we used that experience as part of our study cohort. So we took that group who were familiar with the ICE protocol, and we matched them with a new group that had no protocol. And we had looked at their systems, and indeed they didn't. It was kind of more the doc du jour does the treatment. And we studied them prospectively. We then got together to develop treatment guidelines, sort of a super ICE protocol. And then we put those together and added it to both groups to see what happened. So let's look at the first part. I showed you some of this yesterday, but the reality is when you do research in multiple countries, you get effects you never expected. So it turns out actually that when we looked at our demographics, there were a lot of unbalances. And it had to do actually with countries. The insurance system within one country was poached by private hospitals to bring funded patients to their hospital until the funding ran out. Then they would send them to the public hospital. That kind of thing happens, and you have to deal with it. But that's what happens when you go into sort of other areas where their own practices influence your own data. This was quite difficult to deal with. We dealt with it with propensity analysis, which is basically you weight individual patients depending on their similarities, and you can balance quite effectively demographic differences. So you can actually account for a lot of these differences. And when we did that, very few differences remained. And those we just added into our regression equation. So we managed to balance them. But the reality is that you have to account for very different local practices when you do research in multiple countries. So we ended up with 414 patients here. And as I said yesterday, we had remarkable results in showing that having the ICE protocol did better. Okay. And also there's our Kaplan-Meier survival curve. And then we also did it in the unbalanced group. I'll just say there's the balanced group, propensity weighted. There's the sensitivity analysis in the unmodified group. So it was a pretty strong effect because it didn't have to balance the two groups. Then process variables were also better. One thing we did end up doing is where we seemed more inefficient was we got more CT scans with the protocol. Now, most of us want CT scans, and for various reasons we can't get them, right? The patient has to pay for it, the administration doesn't want to pay for it, and we have a trauma patient who needs one. We wrote into the protocol the necessity of CT scans. So we kind of leveraged CT scans against a system that wasn't set up to let unfunded people have them. That was actually a benefit. I liked that inefficiency. But the rest of things all had strong trends towards improved efficiency, length of stay, ventilator use, et cetera. So having a protocol only makes patients better, but it decreases your use of resources, which is also very important when you don't have enough beds. But the question is it this protocol or is it just having any protocol? Because that's pretty important, really. That was the second part of our test. So this group just went from old to new. This group went from none to new. So this group is actually similar to this analysis here crosswise. So there's very little evidence on algorithm. How do you come up with an algorithm? Well, there's no evidence on it. So you have to do it with experts. And so you get a large group of experts together who've been practicing for a long time, are currently practicing, and are experts in the field, okay? It's the way to develop consensus-based algorithms. Now, how do you pick people to be on that group? As I said, they have to be experts in severe brain injury treatment without ICP monitoring. That's not me. I can't be an expert in that field, okay? I've published a few things and I've taken care of a lot of patients, but I don't know anything because I've always had an ICP monitor. So we had to pick people who had a lot of experience in that area and were still in active practice and involved all disciplines. So we had neurosurgery and critical care. And there was some overlap with some slides you just saw. For instance, Sergio Aguilera from Chile and Andres Rubiano from Colombia were part of this group as well. The consensus process is to come up with individual treatment questions, pass them through that group with blinded voting, and then work out if they agree. If they don't agree, then it has to go back and be iterated. If they agree, it becomes part of the recommendations. And so this was the consensus conference that we had in Buenos Aires in 2015 of this large group of people who've been doing this. And it's currently in press. Journal of Neurotrauma is the slowest journal ever to publish. And we're actually, it's been accepted. It should soon be out. And if you stop playing with it, just leave it, please. Please leave it. This is what we came up with. I said a little bit about this yesterday. Every time you touch it, it seems to stop working. Sorry. A major question is who to treat. And this is not only who to treat for suspected intracranial hypertension, but also plays over into who to treat, who to put monitors in. And again, as I said yesterday, they used major and minor criteria. The major criteria were based on CT. The minor criteria were based on clinical exam. And then this is the schedule for CT scans that leverage the CTs. We set up a minimum number of scans necessary for this protocol, and that actually resulted in an increased number in patients treated by this protocol. We then went through the tiered treatments here. We went then, as I'm going over this quickly because I went over it yesterday. And then we went through the neuroworsening definition for patients who need immediate management. And then we went through tiered treatments for patients who seem to not be getting better, but don't require something radical. And again, this is the idea of how to advance treatments in patients with suspected intracranial hypertension in a method that's safe, using drugs that are useful in this group. For instance, we give mannitol or hypertonic saline when the ICP goes up. If you don't have a monitor, you can't see the ICP go up. So now you need to figure out how to give it. And as you can see here, they gave it on a scheduled basis for these patients. So that's a whole different treatment philosophy based on the reality of no monitoring. Again, hyperventilation was used to some extent, not severe, but used. Hypertonic by continuous infusion, increasing sedation. And then finally, pretty much the same three that end up on all algorithms. But I can tell you high dose barbiturates were almost never used because they don't have the indication for exactly when to use them. In other words, an ICP monitor. And hypothermia is rarely used because it's hard to do in a hot environment. The metodo pescado, which is the fish method, is putting people in ice, but it's a bit of a major effort to do that. And then there were a number of treatments that were not used here, and corticosteroids make sense, but mannitol by continuous lumbar CSF drainage, that will lower ICP, but you have to have a ventric in place. If you have a ventric in place, you have an ICP monitor. This is not your algorithm. So that's the kind of realities that you go through when you do this. The neuromuscular blockade was also interesting because it will lower ICP, but when all you have is imaging, which is intermittent, and the clinical examination, which is critical, losing that is a big deal. So then we came up with this heat map for decreasing monitoring, because this is a really difficult thing. How long do you treat? You can treat forever, and that will take up all your ICU beds with one patient. Or you can treat very short and perhaps have them deteriorate later. So this is, all of these people had one vote. They were all given this algorithm, which had to do with how long the patient had seemed stable, what the CT scan showed, what the Glasgow motor score was, and then the status of the pupils. And again, they're used the traffic light scenario where green is proceed, they would start backing off. Yellow is proceed with caution, and red is do not proceed. So each person had one vote for each of these. Then we added them all together and figured out if they were yellow, green, or red. And so what the people have done in the second part of our research study is they've gone to this and they've put their patient in an individual box and then decided what the box showed so that they could try to sort out what they would do in terms of backing off. Now, let me just skip through that then. So what happens when you do the second phase of this study? Well, this is very preliminary analysis since we've just got the data clean enough to analyze. This is the group, and there were very few or demographic differences in this group, so we could use simple logistic regression. That's neuro. And then we had two analytic models. Probably pay attention mostly to B, because it... Sorry. Yeah, I know, but I can't stop them from doing something about it, so. Okay, good. And Apple produced product strikes again. So just quickly, the groups matched out pretty well. That's what I was trying to say there. And we managed to control for the mismatches using regression analysis and a general estimating equation, which accounts for center differences. That's pretty important actually in international research. So this is the non-protocol group, which then became a protocol group by picking up the new protocol. And there was statistically significant, no matter how you analyze it, improvements in outcome. And you can see here is the spectrum of Glasgow outcome score at 6 months. Quite significant, similar to what we saw in the first phase where we had non-protocol centers and protocol centers. Here the longitudinal is similar to that, and it has the same result. So it's very strong evidence that having a protocol improves outcome. Also, the process variables were improved, so it was more efficient once again. Now, when you added the specific protocol, what happened? It wasn't as impressive. There were trends in all across the board. All the trends were in the same direction to being better, but it was not significant. It was not nearly as impressive. And also, all the trends in improved process variables were better, but they weren't significant. This is both of these. This is the phase 1 and phase 2 for the non-protocol sites. So non-protocol, this is the change to a new protocol. These are for protocol sites, phase 1 to phase 2. You can see the trends are all in the right direction. These are statistically significant. These are simply trends. So again, the money seems to be in having a protocol. So tentative analysis is having a protocol makes a significant difference. The influence of the specific protocol is favorable, but less. The influence of protocolization is much more pronounced for mortality than morbidity. And there appears to be a practice effect during protocol adoption. So the take-home message is really, is if you don't have a protocol, you need to have a protocol. That is the very strongest message. What specific protocol is a little bit less important. It's nice to have something to work off, but a protocol such as this, which you can see soon in publication, is a working tool. You don't have to adopt this protocol clearly, but it's something you can use to make a protocol that works in your system. So all severe patients should be aggressively treated. Just because you don't have an ICP model, you can't throw up your arms. All severe treatment should be done according to shared treatment protocols, the system-wide treatment. Shared treatment protocols should be as comprehensive as possible, and it's recommended that each institution develop protocols to be applied to their patients. So in summary, I put a challenge to this group because I think this group can do it. Tariq is suggesting you're already on the way. We have very strong evidence that protocolization improves outcome. And in general trauma, it's been shown. Now it's been shown strongly in head injury. We have a couple of example trauma protocols that you can use as working tools, and you can adapt them, adopt them, whatever you want to do. But I would have to say that this group has the promise and certainly the skill to change the way Pakistan does neurotrauma to the benefit of your patients. And I think it doesn't require money, it requires organization. And you've already got that organization in a way we'll hear about this afternoon. So thank you very much.